I'm Aggrey Lubikire, an ardent advocate of maternal and child health. An anesthesiologist and intensivist. I've worked since 2000 in the UK for 9 years, and then back to Uganda, and then in Canada, where I did my fellowship at Women's Hospital and Obstetric Anesthesia, and then later went to India for critical care. I'm hoping I'll have the courage to do a PhD again, but yeah, so that's a story for another day. Yes. Occasionally, an occasional DJ. I run a business of mobile DJ, so if I'm not here, I'm DJ Happy somewhere. I'm not Dr. Aggrey. A proud father of 3 and married to one wife who's a woman. Issues to consider when you're doing anesthesia. You have to understand that what is going to kill your patient when they are bleeding badly is either issues of volume and poor perfusion, issues of bleeding, which is coagulation, issues of acidosis, issues of cold, being very cold, which is part of the lethal triad. And then what are your team like? The skills of that team that are going to work with you. That's the midwife, the surgeons, but also do you do simple things like a surgical checklist to just discuss with the team, this is the mother we have at hand, these are our challenges. Do we have all the resources before we dive in? Can we call an extra human resource? Can we call a referral site that we are stuck? Maybe they can send us blood. So all those things, if you can just think about them, they will be important. Then the patient doesn't belong to you. You're just a steward. Have you had a chat with the family that we are having a critical ill mother? We're having these challenges. We are going to do our best and pray for us while you're outside that theater. It is very, very important to involve the family at every end of the way, because sometimes we end up in litigation, but sometimes also they have a negative feeling around us when we just denounce the bad news to them, or sometimes they don't know the challenges we have. And I've seen an instance where we've saved, we lost a mother, but later one of them said, I wish you had told us that your problem was blood, because I'm a universal donor and I have O negative. It was kind of very painful because we got her involved last minute. In your preparation in anesthesia, in a very short time, make sure that you've done a quick assessment of your patient. By default, for anyone bleeding, we should do a general anesthetic. So no role for spinal anesthetic in this instance. And these are mothers that have bled over 1,000 liters or 1.5. If someone has bled less than a liter, there's a role for spinal. But after 1 liter, please go in for general. But you need to assess, because all pregnant mothers have potentially difficult airways. A mother that has also had eclampsia, they have edema in the airway. A mother that has probably been involved in a road traffic accident, then they bring them to you, they are going to have deformed facial features. So you expect a difficult air. And most mothers also have a full stomach. So by default, they are going to be not easy. And then there's the hemodynamic system. Already they are in shock. So you need to assess how bad the shock is so that you can get some quick vitals. Half the time, most of our patients are already unconscious and unrecordable. Then ensure you start with wide bore cannula. If you need to put them in the neck, please ensure they are there and be well secured. At least 2 lines, and sometimes you need to have 4 lines. We are using wide bore because these are lines that have less resistance when you're infusing very fast. So no role for green, no role for pink, no role for blue or yellow. It is gray or orange. In the neck, in the feet, in the hands. And then we need to run a quick baseline investigation. Here we're looking at a quick hematocrit, a CBC, a coagulation profile. We are looking at the PT-INR. Fibrinogen levels are not being done here, but it would be one thing to know because fibrinogen is a good predictor of worsening DIC. Cotet et al. In Canada did a study with 12 other colleagues. So it's a blood gas, which we are not able to do in our environment. But if you're able to do, yes, that would be very good. But immediately talk to the lab people and organize blood. And preferably ask for a ratio of 4 units of packed red blood cells, 4 of fresh frozen plasma, 4 of platelets, and cryoprecipitates. The reason we are doing that is when you've been losing blood, you are losing hematocrit and hemoglobin that are responsible for your perfusion. And also you're losing volume for your circulation. But also you are losing coagulation factors. So from the very word go, you are already disadvantaged. So bringing the ratio of 1 to 1 to 1 helps to restore perfusion, restore circulation, but also restore coagulation straight away. And that's why the reason is for that ratio. The choice of anesthesia. We've talked about having a general anesthetic, so you're going to do a rapid sequence induction because that's the assumption that all mothers are full stomach. So you need a good assistant to help you apply quick pressure and then be able to intubate as fast as you can. But also you need to be sure that your bed is good. In terms of the patient, in case they vomit, can you do a trade and bag? You also need very, very acting drugs. The acting drugs should be the muscle relaxant for intubation, which is normally dexamethasone and rocuronium. And importantly, the 4 things that are going to kill your patient at intubation are 4. We are going to have a mother that is already in shock. And these mothers, when you're in shock, there's the effect of the cardiac. And the cardiac will die because of 4 things. It's either because you've lost so much blood, so the heart goes in shock, and you have poor ventricular contractility. There is also the risk of poor ventricular activity affects the preload, and then that also in turn affect afterload. And then if your shock worsens, then you end up getting arrhythmias from ischemia of the heart. So the drugs we choose that are only very stable currently is etomidate, because etomidate has no effect on the heart. And normal heart institutes uses this. And recently, last week, we had a presentation where we talked to the MLAGO team and the NMS, and we're trying to see if they can actually allow it to be used. But in our environment, also you can use ketamine. Ketamine is very, very good because it increases afterload. And if you increase afterload, then you have increased preload. Okay? So that means the volume of the blood available to the rest of the body increases because ketamine has a adrenergic effect. The challenge is if you have stage 2 and 3 and 4, you have an increased heart rate, and ketamine increases heart rate. Remember, cardiac output is equal to heart rate and stroke volume. So if you have a heart rate that is already around 120, the heart is able to maintain its cardiac output. But the problem goes when you are having above 125 or 130, the heart is beating too fast to fill up. So that's why when you're giving now ketamine, you may have to give a lower dose, because if you're going to give a higher dose, you're going to increase more tachycardia versus the tachycardia of compensation of the shock, and that means your heart is going to be running around like a rabbit. So that's not very good. And then early use of vasopressors. The moment you get a shock patient, get in your drugs, but because the patient is already struggling, just don't give the anesthetic drugs. Start running an infusion of either adrenaline or noradrenaline, so that you intentionally support the heart, but also start squeezing the pipes, which are the vessels. That way you are likely not end up with cardiac arrest at induction, because you can have the good intention and only lose the patient at the start. So to avoid cardiac arrest at the start, have vasopressors ready, which is adrenaline or adrenaline dobutamine. In here, we have adrenaline and noradrenaline in this hospital. But if you're running adrenaline, run low dose as well, because in increasing dose, you can also get beta effects with the heart runs too fast. Then have the choice between inhalation and IV drugs. Inhalation, sevoflurane is the best of all those drugs because it helps, it has a smooth induction, so it does not irritate the mother, so it less secretions, but also it has less effect on the heart. And in that range, isoflurane follows, and in the worst range is halothane. Halothane takes long to induce the mother, but once they take on, then it has a dose-dependent effect on the heart and increases cardiac sensitivity to catecholamine. So you have a bigger heart rate race when you're using halothane for maintenance. And most likely you're still going to arrest. But also to be able to have a uterine relaxation, you need a higher dose. And so typically between the 3 drugs, halothane is associated with more uterine atony and then delayed recovery. Isoflurane is medium, but the best would be sevoflurane. You have a quick onset and quick offset and less effect on the heart. And if you are trying to avoid that, then you can do what we call TIVA. TIVA is total intravenous anesthesia, where you can have a mix like a cook and say, I'll combine low dose propofol for quick sleep and low dose ketamine, and have my vasopressors like noradrenaline in the backup ground. Then you'll have a good smooth induction and maintenance. So you can actually intubate the patient and choose to run IV ketamine, IV propofol as an infusion, and have a backup ground of noradrenaline. Patients will be able to be comfortable that way without going to the gases. When all is said and done during the surgery, when you get your blood, the things that you need to look out for is massive resuscitation. That means you're going to give as much blood as possible so that you pick up this patient from the death. Literally, most patients are unconscious. So we have the 3 R's: the resuscitation, there is revival of the cells, and then the restoration of the organs. Organs are made up of cells. So when you initially give your blood, give as much as you can so that you can pick up this patient from the death. And that means you are resuscitating. And one of the questions that Dr. Najemba had was, how much is good enough? Yes, give as much, because this patient is literally dying, and they are dying because of ischemia and because of perfusion and because of coagulopathy. And once the patient's life starts coming back, that means you've reached the stage of revival. The cells are getting back. Slow down your blood transfusion, otherwise you end up with dilution of coagulopathy. It doesn't mean you don't transfuse, but slow down, and you can say, instead of giving this unit in 1 hour, I'll give it over 3 hours. So you slow down your resuscitation. And along the way, you realize the urine starts coming. It means now you're getting organs restored. So you still slow down. So you have almost 24 hours through which you can actually give as much blood. If you intended 10 units, it means initially you gave 5, and then the other 5 are over 24 hours. Otherwise, you end up doing so much harm by giving all the units in a short time. All patients that have lost more than 1.5 give blood. You replace blood for blood. Patients who are already unconscious, give blood. The patients I always try to give crystalloids are those that have lost a liter, because then at least you have a room for that. And if you have even a colloid, the better. Colloids are good, especially albumin, gelatins, or starches, but they have a risk for increased coagulation problems and also acute kidney injury. So you can give a maximum of 1 liter of that or less than that. And we have Rhizoplaque, which is also an osmotic or concentrated crystalloid. You can as well give a maximum of 800 mils. It's highly osmotic, but a crystalloid. I've talked about this. If you're able to get fibrinogen, you can give it, but if you can't, make sure that you've given your pathogenic blood cells, fresh frozen plasma, and platelets. And if you're still struggling, you can give platelets. The question was, in the health center, how do you know you're having problems? Just